So this deep dive, we're really focusing on the heart structure, how it functions, and also the major blood vessels in your neck.
Okay.
And we're also going to branch out a bit, talk about the peripheral vascular system, the network out in your arms and legs, and the lymphatic system too. That one's key for immunity and fluid balance.
An assessment, right? How doctors actually check these things.
Yes, exactly. We'll touch on assessment techniques and some important health points to keep in mind.
Right. And we're pulling this from chapters covering the heart and neck vessels and also the peripheral vascular and lymphatic systems. So think of us as your guides through this biological map, maybe.
Good way to put it.
Our mission, really, is to give you a clear, engaging understanding of how these systems all connect and work, their functions, how they're assessed, key health insights, but, without drowning you in super technical jargon.
Let's try anyway.
Yeah. So let's kick off with the heart, the absolute engine room. Right?
Definitely the engine room. Fundamentally, the heart is just this incredible pump. Its main structure involves 4 chambers.
Yeah.
You've got the atria, the 2 upper ones, they receive blood coming back to the heart.
Okay, the receiving rooms?
Exactly. And then the ventricles, the lower 2, these are more muscular, and they're the ones that do the heavy lifting, pumping blood out to the lungs and the rest of the body. And crucially, there are valves inside.
Valves, right, to keep things flowing the right way.
Precisely. They ensure it's strictly a one-way street for the blood.
Okay, so chambers receive and pump. Tell us more about these valves. Who are the key players making sure there's no U-turn?
Well, we have 2 main types. First, the atrioventricular valves, or AV valves. There's the tricuspid valve, that's between the right atrium and right ventricle, and the mitral valve, between the left atrium and left ventricle. They control flow into the ventricle.
Got it.
Then you have the semilunar valves. The pulmonic valve sits between the right ventricle and the pulmonary artery heading to the lungs.
Right.
And the aortic valve, that's between the left ventricle and the aorta, the body's main artery. These guys stop blood from washing back into the ventricles after they pump.
Okay, a really tight system then. Entry, exit, no going back. Now, the source material mentions heart sounds, S1 and S2. These aren't like musical notes, are they?
Huh. No, not quite musical. S1 is the sound you hear when those AV valves, the tricuspid and mitral, snap shut.
Oh,
This marks the start of systole, that's the squeeze phase, when the ventricles contract to push blood out. So ventricles are full, valves slam shut, that's S1.
the lub sound.
That's the one, the lub. Then S2 is the sound of the semilunar valves, the aortic and pulmonic closing. This happens at the end of systole, after the ventricles have squeezed the blood out.
So that's the dub, the classic lub dub.
Exactly, lub dub.
The source also notes these sounds have characteristics like frequency, intensity,
Yeah.
duration, timing. Why break it down like that? Why are those details important?
Well, think of those sounds as the acoustic signature of the heart's mechanics.
Okay.
These characteristics, the pitch, the loudness, how long they last, when they happen in the cycle, they help clinicians figure out if the heart mechanics are normal or if something might be off.
Like a subtle change in the engine sound.
Precisely. Changes in those features, or hearing extra sounds or murmurs between the lub and dub, can be early clues about valve problems or other heart issues, sometimes even before someone feels symptoms.
That makes total sense. Listening becomes a diagnostic tool. Okay, let's shift gears slightly. The material talks about how healthcare pros actually assess the heart and those neck vessels. It even poses a scenario, interviewing someone who's had a heart attack, a myocardial infarction. What are the key questions you'd ask in that kind of focused checkup? It's an interesting thought experiment for anyone, really.
Absolutely. In that scenario, you definitely start with current symptoms. Chest pain or discomfort is key. Where is it? How long? What makes it better or worse?
Right.
But also things like shortness of breath, palpitations, that racing or fluttery, feeling any dizziness, swelling in the legs or ankles. You also dig into their past medical history, the details of the heart attack, any other heart conditions, family history.
And lifestyle, I imagine.
Oh, definitely.
Yeah.
Smoking, diet, exercise, those are critical pieces of the puzzle for understanding ongoing risk.
So building a whole picture. Now, the physical exam itself. The source is stress using specific patient positions. Why is getting the patient position just right so vital?
Positioning is key because it optimizes what you can see, feel, and hear. For example, feeling the carotid arteries in the neck. Having the patient sit up usually gives the best access.
Okay.
But for checking the jugular veins, also in the neck, and the precordium, the chest area over the heart, having the patient recline at about a 30 to 45 degree angle is best.
Why that specific angle for the jugulars?
Good question. Think of the jugular vein as a sort of fluid column that reflects the pressure inside the right atrium of the heart. At that angle, you can best see if the vein is distended or bulging, which might indicate increased pressure. Maybe the heart isn't pumping effectively, causing a bit of a backup.
Like a visual pressure gauge, almost.
Exactly. And for listening to the heart sounds, lying flat supine is standard. But sometimes having the patient roll onto their left side or lean forward can bring the heart physically closer to the chest wall.
Making faint sounds easier to pick up.
Precisely, especially useful for subtle murmurs or extra sounds.
Makes sense finding the best listening post. Now, what specific things are clinicians looking and feeling for? Inspection and palpation.
Right. So inspection is looking. You're watching the chest wall for any visible pulsations, any obvious heaves, also checking the skin for lesions or abnormalities.
He's.
Yeah, a heave is like a sustained, forceful outward push you might see or feel over the ventricle area during systole. It could suggest the ventricle muscle has gotten thicker, hypertrophied.
Okay. And palpation is feeling.
Yes, gently feeling specific spots. You might feel for thrills. Those are like palpable vibrations, almost like a purring cat under your fingers.
Oh.
They often indicate turbulent blood flow, maybe from a significant murmur.
Wow. Okay.
You're also assessing for that jugular vein distension, JVD, at that 45-degree angle we mentioned. If it's bulging more than, say, 3 centimeters above the sternal angle, that bony notch where your collarbones meet, that points towards increased central venous pressure.
Right. The backup indicator.
Exactly. And of course, locating the apical pulse. That's usually felt at the 5th intercostal space between the 5th and 6th ribs around mid-clavicular line, roughly middle of the collarbone, feeling its location and character.
So, lots of physical clues. Then comes auscultation, listening with the stethoscope. We listen to the carotids for something called brutes. And the heart sounds. What's a brute?
A brute is basically an abnormal swooshing sound you hear over an artery. If you hear one in the carotid artery in the neck, it often suggests the blood flow is turbulent, maybe because the artery is narrowed by plaque buildup.
And that's serious.
It can be, yes. It suggests compromised blood flow, potentially heading to the brain, increasing stroke risk. So it's a significant finding.
Definitely critical. And when listening to the heart, the sources say to use both the diaphragm and the bell of the stethoscope. Why both sides?
Good point. They're designed for different sound frequencies. The diaphragm, the bigger flat side, is best for higher-pitched sounds like your normal S1 and S2 and some murmurs. The bell, the smaller cup-shaped side, is better for lower-pitched sounds. Things like certain other murmurs or extra heart sounds called S3 or S4, which can indicate specific conditions. Using both ensures you get the full soundscape, basically.
Like having different microphones for different pitches.
Got it. Now, the material also details the specific auscultatory areas where to place the stethoscope for each valve. Can you walk us through that? It sounds like a map on the chest.
It really is, and it's based on where the sound from each valve travels best, following the direction of blood flow. So for the aortic valve, you listen at the second intercostal space, just to the right of the sternum, the breastbone.
Okay, second space, right side.
Then directly across, second intercostal space on the left of the sternum that's best for the pulmonic valve.
Got it. Aortic right, pulmonic left.
Then you move down one space to the third intercostal space on the left sternal border. That's Erb's point, often good for hearing murmurs from either the aortic or pulmonic valve.
Erb's point, okay. Then further down, fourth or maybe fifth intercostal space, still on the left sternal border, that's the tricuspid area.
Tricuspid, lower left border.
And finally, the mitral valve. That's typically best heard at the fifth intercostal space, but further out at the midclavicular line down from the middle of the collarbone, that's often where you feel the apical pulse too.
That's a super helpful guide. Okay, moving beyond just the physical exam, the material mentions other tools like cardiac monitors, 12 lead EKGs. Briefly, what do those add?
Cardiac monitors give you that continuous real-time view of the heart's electrical rhythm. Great for catching arrhythmias as they happen. The 12-lead EKG, or ECG, is more like a detailed snapshot. It looks at the heart's electrical activity from 12 different angles simultaneously. It provides much more info about rhythm, can show evidence of muscle injury, like from a heart attack, chamber enlargement, lots of things.
Deeper insights. Now, this next point feels really crucial for everyone listening. The atypical symptoms of a heart attack, particularly in women. The stat mentioned, like a third don't get classic chest pain. That's huge.
It is huge and critically important. Besides chest pain, women might experience things that seem unrelated, like severe flu-like fatigue, sometimes for weeks beforehand.
Weeks? Wow.
Yeah. Or they might feel a burning coldness or tenderness in their back, shoulders, arms, even the jaw. Nausea, vomiting, indigestion, shortness of breath. These are also really common atypical signs.
So things that could easily be dismissed as something else.
Exactly. The takeaway is vital. Heart attacks don't always look like they do in the movies, especially for women. Recognizing these other signs can literally save a life by prompting earlier action.
Absolutely crucial information. The sources also mention cultural factors, genetics, environment, lifestyle, all playing a role in heart disease risk.
Yeah.
And they list key modifiable risk factors. What are those things we might actually have some control over?
That's the encouraging part, isn't it? Many big risk factors are modifiable. We're talking about things like high blood pressure, hypertension,
Right.
smoking, high cholesterol levels, obesity, and type 2 diabetes.
And those are things people hear about a lot. But it's good to reinforce how directly they link to heart health.
Absolutely. Making changes, healthier diet, regular activity, quitting smoking, and working with healthcare providers to manage conditions like blood pressure or diabetes can make a massive difference in lowering heart disease risk.
It really is empowering to know where we can focus our efforts. Okay, let's shift focus now from the central system to the highways and byways, maybe. The peripheral vascular and lymphatic systems.
Good analogy. Let's start with arteries out in the periphery, arms and legs. What's their job?
Simple enough, really. They're just extensions of the main arterial network, carrying that oxygen-rich blood away from the heart out to all the tissues in your limbs, delivering the fuel and supplies.
Got it. And the veins do the opposite trip.
Exactly. Veins collect the deoxygenated blood, carrying waste products back towards the heart. Structure-wise, they tend to have thinner walls than arteries, and they rely heavily on muscle contractions around them and, very importantly, internal valves. Valves again, just like in the heart.
Similar concept, yes. Especially in the legs, where blood has to travel uphill against gravity, veins have these little one-way valves. They open to let blood flow up, then close to stop it from falling back down,
Yeah.
essential for preventing pooling.
Incredible design. Now, the lymphatic system, often mentioned together with vascular. What's its main gig?
The lymphatic system is, well, it's a fascinating network. It's partly our immune system's home base and partly a fluid management system. You've got major groups of lymph nodes we can sometimes feel in the neck, cervical, armpits, axillary near the elbow, epitrochlear, and groin, inguinal.
Okay.
Plus organs like the spleen, tonsils, thymus are involved. This system filters waste, houses immune cells to fight infection, and crucially, it collects excess fluid and proteins that leak out of blood vessels into tissues, returning it to the bloodstream. It prevents swelling, essentially.
So, part cleanup crew, part defense force, part plumber.
Huh. Yeah, that covers it pretty well.
Okay, so just like with the heart, there's an assessment process for these peripheral systems. The material poses another scenario. Assessing someone with congestive heart failure, CHF. What specific questions about the peripheral systems would be top of mind then?
Right. With CHF, the heart's pumping is less efficient, so you're looking for signs of fluid backup and potentially poor circulation in the limbs. So you'd ask, any swelling in your legs, ankles, feet? When did it start getting worse?
Okay, edema questions.
Definitely. Also, any changes in skin color or temperature in your arms or legs, pale, blue, cold? Any pain or cramping in your legs, especially with walking, we call that claudication.
Right.
And you'd ask about lymph nodes, too. Notice any tender or swollen lumps in your neck, armpits, groin, trying to gauge the impact of the heart failure out in the periphery.
Makes sense. Looking for those downstream effects. Now, visually inspecting the arms and legs, what are the key things to look for?
For the arms, you're looking at skin color, any paleness, redness, blueness, skin temperature, just generally, and size and symmetry. Are both arms roughly the same size?
And the legs. Similar things.
Similar, yes, but maybe a bit more detail. Skin color and temp again. Hair distribution, sometimes poor circulation can cause hair loss on the legs. Visible vein patterns, any bulging varicose veins. And again, size and symmetry, specifically looking for swelling or edema. These visual clues tell you a lot about circulation and fluid status.
Okay, then palpation again, feeling. What are you assessing by touch in the arms?
In the arms, you check capillary refill time on the fingernails pressed down, see how quickly the pink color returns. It's a quick check of circulation to the fingertips.
Less than 3 seconds usually, right?
Generally, yes. Less than 2 or 3 seconds is considered normal. You'll feel for the brachial pulse high up in the inner elbow area and the radial pulse at the wrist, checking their rate, rhythm, strength. You'd feel for those epitrochlear nodes just above the inner elbow. Normally, you can't feel them, so if they're enlarged or tender, it might signal infection down in the hand or forearm. And you assess skin temperature, texture, smooth, rough, and turgor, the skin's elasticity, by gently pinching. Good turgor means good hydration usually.
Okay. And down in the legs and feet, what pulses and other things are you feeling for there?
Again, temperature and texture. Then the pulses are key. The femoral pulse up in the groin, the
Right.
popliteal, trickier to find, behind the knee. Then down on the foot, the dorsalis pedis on the top and the posterior tibial just behind the inner ankle bone. Assessing all those gives a great map of arterial flow down the leg.
Checking the whole pathway.
Exactly. You might check Homan's sign, flexing the foot up sharply to see if it causes calf pain, though its reliability for diagnosing blood clots, DVT, is kind of debated now. More importantly, you check for pitting edema.
That's the one where you press and it leaves a dent.
That's it. You press firmly over a swollen area, usually the shin or ankle. If it leaves an indentation, a pit, you note how deep it is and how long it takes to disappear. It tells you about the severity of the fluid overload, which could be from heart failure, kidney problems, vein issues.
Lots of info from touch. The source also mentions the modified Allen's test. What's that for?
Ugh, the Allen's test. That's specifically checking for good collateral circulation in the hand, making sure both main arteries supplying the hand, the radial and ulnar arteries, are working well.
Why do you need to know that?
It's usually done before you puncture one of those arteries, like for an arterial blood gas sample from the wrist. You compress both arteries, have the patient make a fist, then relax, and you release pressure on one artery. You watch to see if the hand quickly pinks up. It ensures that if the punctured artery gets blocked, the other one can still supply enough blood to the hand. It's a safety check.
A crucial safety check, sounds like. And the Doppler ultrasound, you called it a mini ultrasound. When does that come in handy?
The handheld Doppler is great when pulses are really weak or difficult to feel by hand. Maybe someone has a lot of swelling or poor circulation. It uses sound waves to detect blood flow, and you actually hear the pulse through the device. It helps confirm if there is flow, even if you can't palpate it.
A listening tool for pulses. Got it. And lastly, filament testing for diabetic patients. What's the story there?
Right. This uses a special thin nylon filament. Diabetes over time can damage nerves, especially in the feet peripheral neuropathy. This can cause loss of sensation. Patients might not feel heat, cold, or even injuries.
Which is dangerous.
Very dangerous. They could get a cut or blister and not realize it, leading to infection, ulcers, potentially even amputation. So the filament test checks for this loss of protective sensation. You touch the filament to specific spots on the foot. If they can't feel it, it signals neuropathy and the need for extra careful foot care and education.
A simple test with huge implications for preventing serious problems.
Wow. It's really clear how all these assessment pieces, listening, looking, feeling, using these tools, build a crucial picture of circulatory health.
Absolutely. Each part adds a piece to the puzzle, helping to understand how well the heart, the vessels, and the lymphatic system are all working together, or identifying where problems might be developing. Okay, so let's try and wrap up our deep dive for today. We've journeyed through the heart's basic layout and job, decoded those lub-dub sounds, and looked at how professionals assess the heart and neck vessels. We really highlighted those critical, sometimes missed, heart attack symptoms in women.
Very important.
Then we explored the peripheral highways, the vascular and lymphatic systems, understanding their roles and how they're assessed too, from pulses to edema to that filament test.
And hopefully some aha moments stuck with you, like how valve closures directly cause heart sounds, why patient positioning is more than just comfort during an exam, why we need to know about those atypical symptoms, and just how deeply interconnected the circulatory and lymphatic networks really are.
Definitely. It's an amazing integrated system. So maybe a final thought for you, our listener, to mull over. Thinking about how tightly linked all this is, the pump, the pipes, the drainage, and defense. What subtle changes in your own body might be worth paying a little closer attention to? Not, in an alarming way, but just with more awareness. Maybe something to prompt a question for your doctor next time. Just something to consider.